Good morning, good afternoon, and good evening, everyone. Welcome to our AAMS forum on technology and orofacial myofunctional therapy. My name is Mark Richard Moeller. I am the Executive Director of the Academy of Applied Myofunctional Sciences. So in our short history of about 9 years, we had our first scientific meeting in Rome just over 6 years ago. And we have had about 20 meetings around the world. This is our 5th Congress, which means it has a membership focus. We have 140 plus speakers in 9 symposia tracks. And we have also a keynote series, and this is a forum series. This is the 6th forum out of 9 scheduled. We have 3 more to come. And we have so many key opinion leaders for our emerging field of medicine. It was thought that it would be wonderful if we could get together some of these, leaders in research, leaders in clinical care, and have a guided panel discussion to talk about key issues facing our emerging field of medicine. So today we're going to talk about technology, and we are going to explore really, how technology might help us rise to the challenge. So the challenge is we have reached a tipping point in terms of research. We have a long way to go to establish ourselves in a first tier of medicine. We have to do a validation study. We are now just this month starting to process the paperwork for establishing the International Board for Myofunctional Sciences, which will be a clinical competency accreditation board that'll be international and interdisciplinary. And we are also establishing the International Consortium for Orofacial Myofunctional Education, Orofacial Myofunctional Therapy Education. And that will be an educational competency accreditation board. That will be separate from our AAMS and separate from the clinical competency board, which is in keeping with gold standards, the ISO gold standards for medical accreditation. So this brings us to here today. We have a body of knowledge meeting that was moved from last month. We were going to be in Germany for our institute and my day job, the Academy of Orofacial Myofunctional Therapy. And it looks like we'll have that body of knowledge meeting, which will drive the educational competency, which will drive the clinical competency, and help create standards and parameters for what we have an international research consortium for orofacial myofunctional therapy, which will do a multi-site, large-scale randomized controlled trial to do a proper validation study. So we have a great lineup of speakers here today. I don't know if my co-moderator is in here yet. Yes, he is. Patrice Bergeron. Patrice is a friend and colleague. He is on our program committee for this Congress, and also our scientific committee. And one of the 4 societies we announced at our opening ceremony that we'll be founding is the International Pediatric Orthodontic Society, which we hope to get registered in Geneva, Switzerland by next week, and have it open for business before our closing ceremony on the 26th of September of 2020. So Patrice is an orthodontist based in Geneva, Switzerland. He has a very large practice. He's well known around the world for being a thought leader and educator and speaker. His practice, he has treated at least 5,000 patients that I know of at an early age, being pediatric, much younger than the traditional guidance of 7 years old. Patrice, I know you have a particular passion for technology and its application to healthcare. Would you like to say a few words of welcome?
Yes, welcome to all, and welcome, and thanks to Mark to organize this session, and thanks to all to be here. Yes, I think it's really interesting, because when we focus about all the trouble we've seen about myofunctional, the tongue, the place, and how we can improve the face of the patient, the grow, all what you see, and now what the technology we can use, to improve our diagnosis and after to find a treatment, because there is two ways. First way is how we can improve the diagnosis, and we can use the technology to be more accurate about how we can find the sign of the malfunction and the dysfunction. And the second part is how we can use the technology to propose to the patient treatment, because there is easy treatment, but after there is an appliance. And I think what changed my profession, and my job like an orthodontist for the children, is because now we have the 3D scanner, we can have the impression in the mouth, and we can design the appliance, and it's really more easier for the patient and for the orthodontist too, because if you think about, there was two parts. Why the orthodontists in the world and the people are not doing treatment for the children. I think, first of all, it's because it was not so easy to obtain the impression of the mouth, and at the same time to design the appliance. And really the technology will help us for the diagnosis and for the appliance and for all the people who want to improve the treatment in their practice. So I'm really happy to be on this meeting and to have all the vision of all you together and your experience about how we can improve this technology, this innovation, and for the people, for this new world. It's interesting. So thanks again.
So the subtitle for the meeting today, the forum, is Rising to the Challenge of Diagnostics and Delivery of Care for an Emerging Field of Medicine. So we know now that myofunctional therapy is critically important for orthodontics, even for sleep medicine. We have to do a lot more research. We have to do a lot more work. We have to develop position statements. We have to have clinical competency guidelines, educational competency, but we don't know the prevalence in the general population of orofacial myofunctional disorders and their specific areas. For instance, the pharyngeal wall, maxillary hypoplasia, or whatever there may be. But what we do know is that perhaps there could be hundreds of millions of people who suffer from myofunctional disorders. And when we get better at what we're doing, and we'll talk a little bit about this today, phenotyping patients, and applying technology, it really becomes a challenge. How do we scale up screening, and how do we scale up training for clinicians, and how do we scale up access to care? So we're blessed with tremendous technology and advances in technology, which we'll explore some of that today. But as we kick off, I want to welcome in some friends of mine. We've been engaged for about 10 years. There's an amazing team at University of Sao Paulo, Ribeirão Preto, which is one of the top public universities in Brazil, and which means I think it's one of the top in the world. And we have with us today Luciana Vitalo-Wojtrawicki, and we also should have Claudia Maria de Felicio. Claudia, are you on?
Yes.
Okay, ótimo. And Marco Antonio Moreira Rodriguez de Silva. I don't know if Marco made it in. His internet was a little bit dodgy. But I know Luciana has just a few minutes, and Claudia is going to be here with us longer. This team, I think, is, to my knowledge, the top research team in myofunctional therapy, myofunctional sciences in the world. I went there when I first went into this venture and this journey 10 years ago upon the recommendation of some friends and colleagues like Irene Marquezan, and it was just extraordinary what I saw there. There were people lined up, in a cluster at 6 in the morning who maybe took a bus from Rio de Janeiro, a bus on a bumpy road over mountains, perhaps in hot temperatures, just to wait to get in to be seen by this team. this interdisciplinary team where they had dietitians, pulmonologists, maxillofacial surgeons, orthodontists, really physiotherapists, and myofunctional therapists ready to see patients, look at them, how can they best triage to give precision medicine. And really, they worked so hard to have the best technology, the best resources in order to really do scientific analysis and data collection on how they could validate tools, how they could validate protocols in order to deliver care. So it's been extraordinary to watch their journey, their prolific scientific achievement. But I want to just invite Luciana, to say a few words, and then Claudia. I remember Marco Antonio telling me a story. He came about 8 years ago during an IADR meeting in Seattle to watch one of our courses, and he was so excited. And he told me a story about Claudia Maria de Felicio being someone looking to do a PhD. And he's like, okay, he's an orofacial pain specialist. And the speech pathology department where myofunctional therapy is kind of housed is in the dental school there. And, Brazil has this amazing kind of way of locating different departments within different verticals or different campuses and schools. And it creates a lot of cross-pollination with verticals of medicine, dentistry, even engineering and public health. But he was like, she came to him. She's like, I like what you do. You're a professor. You're doing science. You're doing research. I want to do what you do. So he's like, tell me what you do. She's like, well, I'm a myofunctional therapist. He's like, really? What's that? Well, we re-educate chewing, breathing, swallowing, oral rest posture. He's like, okay. So do you have objective measurements for those things? And she's like, well, maybe not so many. We're early days. We're just getting started here. And he's like, okay, that's where we start. We've got to get science. We've got to build on a foundation of science. And she's like, that sounds great. I'm in. So it was a great journey, and they've produced so many great students and alumni. And Luciana, do you want to come on and say a few words?
Mark, acho que poderia começar pela Cláudia, né?
Sim, não, porque eu sei que você tem aulas. Você primeiramente, eu he falado com Cláudia antes.
Ótimo.
Ela sabe.
Ok. Desculpe, então, eu gostaria de agradecer essa oportunidade, parabenizar você, né, e todos pela organização desse evento tão importante, e que está, né, aí trabalhando pela motricidade orofacial no mundo.
So Luciani would like to say she greatly appreciates this opportunity and the organization of the organizing committee and this Congress. And she's extraordinarily passionate about sharing myofunctional therapy around the world.
Bom, Mark, eu vou falar brevemente do meu trabalho, é isso, né, em relação à minha linha de pesquisa, minha linha de trabalho. E aqui em Ribeirão Preto, junto com a professora Cláudia Maria de Felício, né, que coordenou até há pouco aí, coordena o nosso grande centro crânio-facial de pesquisas, né, o NAP crânio-facial, onde nós conseguimos muitos instrumentos de alta tecnologia que têm contribuído e melhorado muito as nossas pesquisas na área de motricidade orofacial.
So she would like to acknowledge Claudia Maria de Felicio's great leadership for their team, and that they have a craniofacial research center, which is very focused on delivering the best care possible. And really, this fundamentally involves technology. And this is a critical part of their research.
Eu tenho pesquisado desde o meu doutorado, né, pacientes com deformidades dentofaciais, então aqueles que fazem as cirurgias ortognáticas. Então, o meu trabalho já tem vindo há longos anos estudando os aspectos morfológicos e funcionais num tratamento integrado, né? Cirúrgico, ortodôntico e a terapia miofuncional.
So her particular area of interest, one of them is maxillofacial surgery, orthodontic surgery. And their approach is very interdisciplinary. They include orthodontic intervention, orthodontic surgical intervention in conjunction with myofunctional therapy.
Então, pesquisas usando tecnologias desde a época do meu doutorado, como ultrassonografia, estudando a musculatura mastigatória, né? Eletromiografia, instrumentos de forças, aí orientando outros alunos de pós-graduação, nós avaliamos a eficiência mastigatória desses sujeitos, né? Com a deformidade e ao longo dos anos após o tratamento integrado. Então, eficiência mastigatória, as forças mastigatórias.
They have longitudinal studies underway and on an ongoing basis. They have many doctoral candidates. They have many students. They're constantly looking at chewing and morphological aspects and craniofacial aspects, and it's really also specifically related to function. They look at electromyography, they look at technology, really anything that they can. And it's very interdisciplinary, and this is really essential to their work and what they feel is important for myofunctional therapy.
Mais recentemente, eu tenho usado o escaneamento a laser, né, que analisa a morfologia tridimensional de tecidos moles, e a sua relação com os aspectos funcionais, com a força de mordida, e com vários aspectos da condição miofuncional orofacial, inclusive com o protocolo clínico, né, que a professora Cláudia desenvolveu, que é a avaliação miofuncional orofacial. Então, a gente tem associado instrumentos de alta tecnologia a instrumentos clínicos também.
They use clinical instruments, they use advanced scientific equipment that they bring in to do analysis. They do analysis on bite strength. They do analysis, they've been using lasers to do assessment on the craniofacial morphology. They really, in addition to what Luciana said, every time I go there, it's some extraordinarily new, like, glimpse into the future. They look to bring in advanced engineering of things that are not even available in the market, just to see that if there's a scientific application to help them uncover some secret or some kernel of truth in our collective work.
Bom, basicamente é isso. Também temos estudado os pacientes com apneia obstrutiva do sono, pacientes desde crianças, né, na infância, pacientes adultos também que têm esses problemas aí de distúrbios do sono, traumas de face, que é uma atuação que a gente tem aqui no Brasil, né, muito forte nessa área de intervenção fonoaudiológica, né, da terapia miofuncional. E acho que
they've been doing advanced research and validation of their tools. For instance, she mentioned earlier the Orofacial Myofunctional Evaluation with scores, which they validated for things like sleep apnea. They also are looking at facial, trauma victims, people who've maybe suffered a gunshot or a traffic accident or burn victims. Also, obstructive sleep apnea, whether it be in infants or children or adults, this is a critical part of what they're examining and looking at. and they think is important in terms of myofunctional therapy applied. And they look at also at speech problems, of course, for application.
Ok.
Okay, well, muito obrigado. And in my day job, I manage a private institute based in Los Angeles, the Academy of Orofacial Myofunctional Therapy. And we've been in some ongoing discussions with their team at University of Sao Paulo, but they gave me permission to make an announcement. We're working on making live and active a strategic partnership where we will be able to help send people for advanced study and research projects with their amazing team there at University of Sao Paulo, Ribeirão Preto. And it's a great campus, it's a beautiful garden setting, and it's an amazing city in the mountains in Sao Paulo state. Many coffee barons and plantations sprung up around there in the 19th century. So there's extraordinary wealth and architecture, and it is also a very famous university worldwide for biotechnology. So there's a lot of potential for great science, and if you're curious about advanced study or research opportunities, please get in touch with us. You can contact them at University of Sao Paulo, Ribeirão Preto, or me at the Academy of Orofacial Myofunctional Therapy. So thank you very much, Luciana. I'd like to welcome now Claudia Maria de Felicio, who is going to share some slides. And this is just an example of some of the technology that's applied with some data that's resulted from it. And we're working on establishing a scientific journal for our society because the research literature is scattered across so many different journals, so many different subject areas: pediatric otolaryngology, speech pathology, orthodontics, sleep medicine. And so when people go to study myofunctional therapy or look at the literature, sometimes the keywords or search terms are different, and there are so many different journals that are touching our world. We're really excited to be starting to get our own journals. So Claudia, we have your slides up. If you want to introduce them, my colleague Samantha will move the slides along when you're ready. Thank you.
Bem, estas são imagens da Faculdade de Medicina, Hospital das Clínicas de Ribeirão Preto, Faculdade de Odontologia, onde nós atuamos. E aqui uma imagem do nosso laboratório, que o Mark gostou muito dessa árvore.
So these are images of their campus, of their medical school, where the School of Dentistry is housed within the School of Medicine, and their craniofacial research laboratory.
Bem, considerando o tema, Considerando o tema da apresentação, nós precisamos de métodos não invasivos, mas também confiáveis e válidos para entender os músculos, as funções e as disfunções, antes de selecionar metas e estratégias terapêuticas. O primeiro instrumento que nós desenvolvemos é um instrumento subjetivo, porque depende da avaliação do clínico, porém nos permite expressar os resultados em valores numéricos, ou seja, permite medir o distúrbio miofuncional.
So, non-invasive, reliable, and validated tools are absolutely essential for understanding the functions and dysfunctions for therapy, for myofunctional therapeutic goals and strategies in order to achieve success. So this has been really their fundamental approach that's driven their science, is in order to address what they consider to be orofacial myofunctional disorders. They've worked to build on a foundation of science to establish objective measurements, reliable and repeatable results through validated tools.
Bem, o protocolo de avaliação funcional orofacial com score, foi desenvolvido por mim, com a participação de alguns alunos, e ele é usado clinicamente e na prática, né, de pesquisa, mas ele era disponível apenas em papel. E nós, então, desenvolvemos uma versão do protocolo para web e investigamos a sua usabilidade, a satisfação dos usuários e como os usuários aprendiam a usar, se era difícil ou não.
So fundamental to their approach is starting with validation. And, their tool, which is validated across many different categories, the Orofacial Myofunctional Evaluation with scores, which, for instance, is validated for sleep apnea patients, orofacial pain patients, elderly patients, facial trauma patients. They're working constantly to update this and move it along and make it further accessible. So, for instance, they have an electronic version, which they invite people to use for data collection. And this is available online, and it can be easily put into an iPad or another tool for data collection and for patient intake, even in a very simple clinical setting.
Bem, nós também utilizamos de instrumentos tecnológicos e medidas objetivas. E eu vou exemplificar com alguns resultados de pesquisas voltados para a área de desordem temporomandibular. Pode ir.
Se continua, perdão.
Um dos estudos que nós fizemos, a nossa questão de pesquisa é se os pacientes com DTM crônica e deslocamento de disco com redução mostravam uma reorganização da atividade muscular e, se isso acontecia, como era afetado pela severidade dos sintomas de DTM. Com você.
So, just to make a little introduction, Brazil, like Germany, is a country that has specialty recognition for orofacial pain. Not all countries have that. I know the United States has been working on achieving that and may be making some progress, but Brazil has been a leader in orofacial pain for quite some time. And Marco Antonio Moreira Rodrigues da Silva, who is kind of like maybe the grandfather of these sciences behind myofunctional therapy, who I mentioned earlier, he is an orofacial pain specialist, and he's recognized as a world leader. And so this work, for instance, for orofacial pain or temporomandibular joint dysfunction or disc displacement, they're constantly looking at using technology to get objective data. And so they're looking at patients, they want to get high sample numbers, and they want to get objective measurements always, so they can report and understand and learn from their research.
Próximo. Bem, nesse estudo nós concluímos que pacientes com desordem temporomandibular, principalmente aqueles com sintomatologia severa, mostraram uma prevalência de mastigação unilateral, crônica ou preferencial, tinham uma menor simetria na musculatura mastigatória e durante a função de mastigação, e tinham um recrutamento mais alto do lado de balanceio, consequentemente um recrutamento menor dos músculos do lado de trabalho, proporcionalmente, recrutamento relativo, desculpa. O que resulta em uma pior performance funcional.
So, for instance, in this data from this one particular study, they're looking at facial asymmetries and, unilateral chewing preference on one side, and, the amount of, correlating chronic pain in order to understand the functional performance that's related in these kind of patients presenting these kind of problems. So they look at gathering this data, getting very clear analysis, and using objective tools in order to understand the fundamental science involved in order so they can advance and develop clinical protocols to help these patients.
Sim. Num outro estudo, também com pacientes com desordem temporomandibular crônica, nós analisamos por meio da análise tridimensional, tridimensional do movimento, né, cinemática, nós comparamos indivíduos controle, saudáveis e pacientes. E os pacientes mostraram uma quantidade maior de desvio de abertura e fechamento na trajetória, reduzida a velocidade de abertura, assimetria na laterotrusão, né, assimetria entre direita e esquerda, e assincronia na translação condilar, na abertura e fechamento. Nós analisamos a relação entre o resultado do score total do protocolo AMIOF e com os índices na abertura e fechamento, rototranslação e laterotrusão. E encontramos valores significantes nessa correlação. Ou seja, a cinemática mandibular reflete tanto o comportamento motor orofacial, medido pelo protocolo AMIOF, quanto mostra uma adaptação ao deslocamento de disco articular, o problema intraarticular.
So in this example of the data, they're looking at three-dimensional analysis of jaw movement in patients with chronic orofacial pain or temporomandibular joint dysfunction and disc displacement. So as would be normal in any kind of scientific clinical analysis, they look at having control populations and as well as these patients, so they can get objective data and can collect this data. And in this particular case, they came up with quite significant results.
Nesse estudo, nós analisamos se os pacientes tinham dificuldade para mastigar, prejuízo miofuncional e medimos a força de língua. Sim, eles tinham maior dificuldade para mastigar, pior condição miofuncional, menor força de língua, e esses valores foram correlacionados, então nós chegamos a essa conclusão. Em seguida, próximo. Ai, desculpa.
So in this particular study from 2019, they used the IOP device for measuring tongue pressure, and as you might expect, the orofacial pain patients, the myofunctionally disordered patients, had a much weaker tongue strength than the control group. And, the correlating difficulties in chewing, I think, leads to indications of potential algorithm in correlation with this patient population.
Essa menor força de língua que nós vimos no estudo anterior se reflete na pior condição também da deglutição. Então, nesse grupo de paciente, nós verificamos que eles demoravam mais para deglutir, ou seja, a duração da deglutição chegou a ser até 3 vezes maior na deglutição de líquido. Além disso, eles tinham um menor pico de atividade do músculo supraioide, que é o principal músculo da deglutição, que o controle, e, consequentemente, uma participação aumentada dos músculos da mandíbula, os músculos elevadores da mandíbula, e também do esternocleidomastoideu.
So in this study, they wanted to explore the orofacial pain or myofunctionally disordered patients' difference in muscle function during swallowing. And, in their analysis versus the control groups, they showed a lower peak activity of the suprahyoid muscle and increased participation of the anterior temporal masseter and sternocleidomastoid muscles. So, this is an example of the technology applied in order to further understand the phenotyping that could be involved in these patient populations. And this will allow us to move towards a better understanding of what exercises we hope we can apply for solutions. Next slide.
Ficam aqui alguns exemplos das nossas publicações. Esse foi o último da semana passada. Tem o texto disponível sobre terapia em inglês pela Springer. E todos esses resultados que eu apresentei, eles indicam claramente que pacientes com desordem temporomandibular precisam de terapia miofuncional orofacial. Com você, Mark.
Well, these are just an example of some of their prodigious output, their literature, and we're really excited. Just Friday last week, they had a launch of this textbook on myofunctional therapy, theory, evaluation, and therapeutic strategies. So we're really excited. I'm hoping we have a little fledgling imprint for publishing with my institute, and we're really excited we hope to be able to translate this into English. But we thank you very much for your leadership in science and application. Muito obrigado para sua liderança, and we look forward to many more intercambios or exchanges so we can get more research going around the world. Thank you very much. I want to move on to our next subject now. We're going to talk a little bit about how do we scale up a population. So a dear friend and colleague, Darius Logmani, who is head of sleep for Advocate Health System, which I think may be the largest private health system in the United States with about 40 hospitals and 2,500 or 3,000 clinics. I don't know. It seems like it grows every day. In full disclosure, our institute has a relationship with Advocate and exploring how to deliver care on a clinical basis there. So welcome, Darius. Thank you for being here today.
Everybody, I'm sorry to join late. We have a program that we're calling our Population Sleep Health Program. I think the main difference between our sleep program and like a sleep disorder center is we're trying to think about actually health promotion. So if you think about health, you could think about it in kind of three different ways. One is like the treatment of disorders, treatment of disease. And that's something that our healthcare system, at least in the States, is really good at, is actually primarily focused on. Whether we're good at it or not, I think is debatable. But it's the main thing that gets our focus and our attention and our money. Most research is done on testing different treatments, different evaluation methods. And it's by far the most expensive type of care. If you go kind of push one level down, we start thinking about preventive medicine, right? We start thinking about like, how do we identify disorders before they become full-fledged disorders? This is where you get like colonoscopies, you get blood pressure screening. And this idea of how do we start to actually shift like the health of a population, though, you actually need to be even further closer to the grassroots. You start looking at things at the level of culture. And this is something that I think that in myofunctional therapy has been really clear, and the approaches have been focused on that. Like where you see like the study from Brazil that I talk about all the time, where they were looking at how do we draw on teachers as the people that are screening for myofunctional disorders, because they're looking at the kids. They know the kids that are mouth breathing all day, and they know the kids that are at risk. And so starting to use people that are in the lives of these children, because whether or not a child is a mouth breather is like the ability to detect that is actually more complex than we think. Like the number of patients that, I don't know if you guys have had this experience, but you ask somebody like, does your child mouth breathe? And they're like, I don't know. And so we have to figure out what are the questions that help us help us raise awareness of what are the signs of mouth breathing, when is it a problem. So teachers are in a position to do that. Parents are in a position to do that. But even that is just at the level of prevention. And so while I think there's a growing body of data that shows the utility of myofunctional therapy in terms of the treatment of disorders like obstructive sleep apnea. What I'm interested in is how does this become actually incorporated at the level of culture, so that people know that mouth breathing isn't just another option. You can breathe through your nose or through your mouth. We say there actually is an optimal pattern of breathing, and it's nasal breathing. And so how does that start to get out there? So while we need to have like myofunctional therapists that can function at the level of like the clinic, where I'm seeing a patient with obstructive sleep apnea, I know that I need somebody to help support their like just establishing those new neural patterns to breathe through their nose. We also need to have people that are just promoting healthy practices, like how do children chew? How are we helping mothers know they transition rather than transitioning to a bottle, you're transitioning to a cup? You know, these are things that like societal patterns actually influence much more profoundly than physicians do. So this, like how we actually access that is kind of it's where a lot of our thinking is going now, because the resources at the level of community are abundant, right? We're always thinking about, are there enough myofunctional therapists? Are there enough pediatric sleep doctors? I mean, I think the count of pediatric sleep doctors is still in the low hundreds. Like the last count I heard was 300. And then you start looking at the number of kids with obstructive sleep apnea. And then beyond that, the number of kids that just snore. Now beyond that, the number of kids that are mouth breathing. We can't do this. It's actually physically impossible for us as practitioners to do this work. We have to actually tap into the resources that are abundant. And when I say they're abundant, the number of people that love a child is actually significant. How are we leveraging the relationships that exist around a child and raise awareness of the needs of what is ideal, and how do you act, and then giving them access to the system. So those are the things that we're thinking about now in our population sleep health model, where we're responsible now for 290,000 kids just in Illinois that our health system is financially responsible for. So when you start running the numbers, we're talking about tens of thousands of children with snoring. And the question that we don't even know how many of those kids are breathing through their mouth. So what I'm excited about with spaces like this is just raising, like I'm sharing my problems with you all. And so like, hopefully like we'll be able to think together about how do we start to influence, in addition to trying to shift the culture of medicine to incorporate these ideas. We also want to be able to think about how are we actually socializing these principles? How are we helping everybody know that the goal of treatment of obstructive sleep apnea is returning to nasal breathing both during wake and sleep. I appreciate it. Thanks so much for this opportunity to come and to be with you all. Some of you all are old friends, some of you I'm just meeting, but thank you for including me in this work.
Darius, I know you wrestle with this question on, what technological solutions can we use to make these populations change their culture, to bring change to these populations. If you were able to speculate or even dream, 5 years or maybe even 2 or 3 years down the road, what kind of things could you imagine taking place and see into actual practice?
I mean, one thing that, like, again, along the lines of like moving away from that idea of treatment to health promotion, I'd love to have a list of the activities or the exercises that any child could do. Should just be able to do very easily. Like, and then to say like, these are the things that we know that if every child is doing this, that the trajectory of their health is going to get better. Because then those are things that we can start to incorporate, like the arts around. I mean, we've seen these books about like how do we help kids remember to put their tongue on the spot, or that dad shouldn't be snoring, those kind of things. If we can identify just a couple simple things, there's a range of approaches that it could be through books, it could be through technology. But I think that that's the main thing that I'm thinking about, is less how are we identifying disease and more how are we building strength in kids.
Thank you very much, Darius. We're going to shift gears now, kind of we started out with application of science and myofunctional therapy via technology, and then we went big picture. Now we're going to get granular and look at, detection, analysis, screening. Tara Hart is the Chief Executive Officer and President of IOP Medical. And it's a tool that we in our institute love to use in our clinics, and we teach with it, and we teach everyone who studies with us that this is an essential part of a great screening regimen. It was great seeing the team from University of Sao Paulo, present a paper on that. But Tara, can you come on and speak?
Yeah, absolutely. Well, I was very inspired by what you just said, Darius. So I think I'm going to share a little bit about our product to make sure you all know what it does. So I just wanted to quickly introduce everybody to the IOP, just so that you can see what it does. And then I want to sort of talk about the possibilities of IOP currently for OMT, and then also dream a little bit about the future. So what I want everybody to understand is that the basis of the product is very simple. There's a bulb that goes in the oral cavity. You can measure the tongue or the lip with the bulb. And it's an air-filled bulb that measures pressure. That's all it does. Our product can measure strength, it can measure endurance, and it's an objective measure. So my father is actually the inventor of the product, and he was the first one to consider measuring the tongue strength objectively back in 1988. The product was first on the market in 1992, so we've been around for 28 years. And the way we measure strength is looking at the pressure that you can generate in an air-filled bulb when you press and compress the bulb as hard as you can. And we interpret this measure as strength. Endurance is another measurement that's used with stroke patients, for example, in the field of dysphagia. And that's how long you can hold half of your maximum. What the IOP can measure is based on where you place the bulb. So typically we place it in the anterior oral cavity for strength or endurance for the anterior tongue. You can also move it posteriorly. You can measure saliva swallow pressure, effortful swallow pressure, lip strength. And you can also use it for awareness training. So if you have a patient, or particularly like a child, and they're not aware of where their tongue is, if you place the bulb where you would like them to move their tongue, then you can use the biofeedback on the device to show them that they're activating and compressing the bulb in that location. So this is an example of how the tongue would compress the bulb if it was in the anterior cavity. So the bulb just goes behind the alveolar ridge, and the tongue lifts and compresses it against the hard palate. We do have normal values for the tongue. These are for young, middle, and old populations. There are also some childhood norms as well. So you can see whether the patient is in sort of the normal range of about 40 to 60, or whether they're abnormally low. This is the posterior position. So the tip of the bulb kind of goes at the transition between the hard and soft palate. You want to go just ahead of the gag reflex for sure. So some people try to put it as posterior as possible, wait until the patient gags and come forward slightly. But when we had to draw it, we chose to put the tip of the bulb at the transition between the hard and soft palate. The bulb has been used for lip pressure also. Originally, it was placed between two tongue depressors and then placed between the lips. But we found you could get the same measurement by going underneath the orbicularis oris and placing the edge of the bulb just outside the front incisor. This way, too, you can measure right versus left lip measurement, and you can compare the two. So in stroke patients, you might have one side that's lower than the other, and you can use the good side as a control for the weaker side. I don't know if Carlos is going to be talking about his exciting research that was published recently, but this is an inventive research study using our product in the field of OMT, where he looked at the IOP measurement, the peak measurement, to identify the obstructive sleep apnea site in patients. And hopefully he'll be sharing a little bit more about that as well. All right. So I'm done with the slides. So, moment here. What I'd really like to do is talk about what I was inspired by Darius about, which is, again, this concept that this is an air-filled bulb that measures pressure. And typically it's been used with dysphagia patients. It's used preventatively for head and neck cancer patients, and then prophylactically with primarily head and neck cancer patients. But in the field of dysphagia, in dentistry, I've always been inspired about the idea that if you had the normal values of children, and children are seeing the dentists on a regular basis, if they were to measure the tongue strength over time, just like you do weight and height charts at the doctor's office, you could do tongue strength pressure over time. And then if you look at whether they're following in the normal pattern or if they fall off of normal at some point in time, you then beg the question of why are they no longer developing normal tongue strength? And then you can question that and maybe send them to an OMT to look at how they're using their oral muscles. Does that make sense?
Thank you very much, Tara, for your work and your technological leadership in giving us tools that we can use on a daily basis in our clinics. We're really excited about your new updated software applications, and we're really excited about algorithms that can come out of that can help us get closer to phenotyping certain kind of situations and issues. Next, I'd like to introduce Maxime Elbaz. Maxime is he's a friend. He's based in Paris. He works at Hotel Dieu, which has the largest sleep lab in France, and one of the largest in Europe. Maxime recently finished a term as president of the European Sleep Technologists Association. He's a colleague with Damien Leger, who just finished a term as president of the French Sleep Research Society. So he has developed at the Center for Research and Interdisciplinarity, along with the hospitals of Paris and private venture capital funding, an app called iSleeping. And so, we need to democratize diagnoses. And what could be simpler than having an app that you can put in your phone and, do a little analysis at bedtime? I'm excited about applications more beyond just snoring, but, with questions related to myofunctional disorders as well, and specifically myofunctional therapy. So thank you, Maxime. Bienvenue.
Merci. Thank you very much, Mark. Can I share my slide?
Yeah, yes, bien sûr.
I don't have I can't share. Okay, so I will present some functionality of iSomay app and the new app for the Apple Watch. We think that it's very simple to use in real life because we can screen all sleep apnea adult and children patients in our lab and in all the labs. So this is a validate sleep application in France, and I will show you. Okay, I will show you. Oh, so I can show that there is three functions of this app. The first function is like actigraphy. We can track not sleep but actigraphy, motion, the body movement. Like you can see my body movement during my night in a few years ago. So we are the threshold of sleep, inactivity, and activity. And you can see here there is a wake detection during the night. Wake detection here. So we focus about the threshold. We have the new threshold from detecting sleep and wake. And here you can see, like in actigraphy, time in bed, sleep onset, total sleep time, number of awakening, WASO, and sleep fragmentation. So this is I think, interesting app to track sleep and wake during weeks, and we can track snoring by the microphone of the iPhone. We just put the smartphone beside the bed, and we can track the level of snoring here, as you can see here, and you can see the maximum of decibel during the night. And we just focus about how the patient can breathe with the microphone. Here we have the summary of the app, so we can track total sleep time, WASO, number of awakenings, sleep onset, breathing. It's not apnea, it's like apnea, but it's not apnea. It's a cessation of breathing, and the decibel, maximum decibel, and you have some schedule about daily, weekly, and monthly about your sleep data. And now we focus about Apple Watch, because it's more accurate to track sleep like an actigraph with an Apple Watch. It's a new version. We released in March, last March, just before the lockdown. And this is this app. It's called iSleep Watch, and you have the English version and the French version, and it's very simple. You just set up your alarm, sleep alarm. You have your journal, sleep journal, and you have like the sleep app, the sleep time, sleep efficiency, sleep latency, time in bed, and you can see here the representation of time in bed of the sleep-wake schedule. Here you can have, we put in our algorithm a new function, is the risk of apnea. So we detect apnea by the microphone of the Apple Watch, and we can detect, not as accurately as a polysomnograph, but we can have a tendence of risk apnea by the snoring and by the respiration from the microphone, and you can see during the night the snoring in the Apple Watch, and hear the heart rate. So we think that it was an idea with Damien Léger and Christian Guilleminault. And when I defended my thesis in few years ago, Christian told me you must go forward with the Apple Watch, with sleep wearable. So this is the future. So we think that it is the future, and we think that we can record snoring, sleep-wake in real life. That is very important, because we can screen a lot of people now. So if you have some questions, thank you.
Merci beaucoup, Maxime. I'm so excited about the prospect of getting some good protocols with data, using these kind of wearable tools that are so readily available now, and seeing the correlation between, we see high correlation between what we would call myofunctional disorders and sleep apnea. But, getting and charting progress and making sure that, patients are improving, using these kind of wearable tools is really exciting. I'm very happy to introduce a friend and relatively new colleague, Harold Hubro-Strom, who is an ENT and sleep surgeon at University of Oslo and Akershus University Hospital in Oslo, Norway. I had the pleasure of going and speaking in a few different areas and giving a presentation that the Norwegian Sleep Society helped put together. And lo and behold, I wound up on the front page of a newspaper there. So we know that there's some interest here, and just like what was it, snorking, or I don't know what was it, Harold?
Yeah, it was. It was about sleep apnea and how to use this exercise.
Yeah.
It was really, really cool.
Well, welcome. Thank you for being here today and your contribution to the Congress.
Thank you. Muito obrigado. Following inglês. I had this presentation in track number 7, and the reason I could share this was that I submitted a proposal to the Horizon 2020 application this spring with Dr. Erna Sif Arnadottir in Iceland. I don't know if you know her, but she's a very prominent Icelandic sleep researcher and the leader of the ANSS for some years, part of the European Sleep Research Society. And she managed to gather a large application with a lot of European countries. This is the basic idea of this application. So the thing is that we have a central cloud, and this cloud gathers information from NOx devices, from a company called Withings, and also from other applications, including a sleep diary that we have developed in Norway. And the leader of the sleep diary platform that we have used is presenting after me. But the thing is that in order to best communicate between the healthcare staff and the patient, we need to be able to integrate information from a lot of different devices. And the really tricky thing here is the person security part, because who is going to own these data? And for example, if we go to the next slide, the most typical thing here, for example, in the iSleep application, if you in the consumer market, the patient gets this app in the Apple Store, and then the patient uses this kind of application, and he might tell it to his doctor or healthcare provider, but still it's a personal thing for the patient what kind of technology to obtain. So in some cases we might be able to do something like this, that the patient has one kind of device, for example, our sleep diary, and then we can have also some kind of a telemedicine connection with the patient. Or what we're working about in our project just now is to make a written communication channel between the patient and the doctor. So that means that the doctor and the patient can communicate, and the patient can choose to share some information with the doctor from, for example, Dr. Elbas's application. But I think in order to sort of get momentum on this, to be able to provide real biofeedback, we need to be able to in some way share data. So hopefully in the future, I hope we could maybe manage something like this, that sort of we have a lot of different applications or devices or measurements in any way. And if we could get this into a joint cloud, and both the patient and the doctor could have some kind of access to that cloud. But the really hard thing then is who is owning this data. So I think I want to stop there. I hope we can discuss this, because I think this is a key element, not to think one single device or single measurement, but to think how can we integrate this kind of data.
I thank you very much, Harold, and I'm really excited about you coming into the world of myofunctional therapy. And some of you may be familiar with some of their work there. They're very collaborative. They have some great leaders, like you mentioned, from Iceland, from across Scandinavia. But they're also, looking to collaborate around the world, and they're beginning to collaborate with us. And there's a great set of patients that they have with sleep apnea that they've followed for many years. And some of them are CPAP tolerant, some are not. And I'm really excited about the prospect of you going into this patient population and seeing how myofunctional therapy might impact their lives. But thank you, thank you, Harold. And Peter, who's a colleague of Harold's, who manages this technology platform, is one of the leaders of this Capable project. Peter, would you like to come on and say a few words? We have a lot of black boxes around the world in terms of, data collection opportunities, and to have nimble people looking and willing and able to customize these applications is very exciting. Peter, are you there? Peter Herlin.
Yeah, sure. I think I'm here. Anyway, can I share a screen as well? So thank you for inviting me. This is fairly far from my areas of expertise. I'm a radiologist and also computer scientist. So I must say I'm amazed with all that you have achieved. So congratulations on that. I've had the pleasure of working with Harald on a sleep diary project, and Harald asked me to give you a little background on this. So I'll try to do that briefly if I'm able to share the screen. Yeah, I hope it's working. So we have a research product called Capable, funded by the Norwegian Research Council. And the focus in the project is really how to empower citizens to actively use their health information. Can we know that there's a lot of scattered health information around in different systems and different applications. They're not always easily accessible. We want to see how, in part, how we can enable active use of information, and partly to study what you actually want to do with the information once you have access to it. So that's the essence of Capable. We have involved patient organizations and companies, research groups, and the HL7 International, which is a standards organization. So let's see if I can move around. So the Capable project really focusing on how to, how to share information, how to take care of information, how to store it, how to do whatever you actually want it as a patient. So we've been discussing with different patient groups, and I think there are at least some very basic requirements that they all come up with. And the first is that if you want to have a tool to store and share your information, you should have full control over this tool and this information, no one else but you. It has to be GDPR compliant, at least in Europe, and so we've done all the formalities to be GDPR compliant. We're non-for-profit. We do not sell your information. That's kind of one of the problems with previous attempts doing something similar, is that people don't trust what we will do with information, because information might be valuable to some. So we do not share your in full control of your information. Of course, you want to access it wherever you are. So it's a cloud-based and a REST architecture, which is a basic internet kind of thinking. Deploying universal design principles. And as I said, we want as much as possible to base our work on standards. And in e-health, the main standards body now is the HL7 and the HL7 FHIR communication protocols, which is also now embraced by both the European and the international ISO standardization organization. So we're applying the standard. This way of doing it actually awarded us with the Trillium 2 prize, which is on international patient summary work. So it was awarded in the HIMSS conference last year. So of course we were proud of that. This is really the basic thinking of the capable product. I mean, you as an individual, as a citizen, you're in the center and the top. You should be in full control. You should have access to information from healthcare, from hospital care, primary care, the pharmacy, from your gadgets, and from your whatever you want to add. You should be able to share it with anyone if you want or not. You should be allowed to do whatever you want with it. And of course, also edit and delete it. So that's kind of the basic principles we see in a tool to manage and organize and share and store health information from a citizen perspective. And so our first kind of test verification example was the sleep diary. So that's where we've been working with Harald. So we just thought we needed an example where the patient adds information themselves. So that's what Harald specified and we implemented. So the data are stored not on the gadget the patient is using, but in the cloud. They can do whatever they want with it, and they can of course choose to share it with Harald, and that's kind of the idea of his research project. So they're doing that, but that's really up to them to decide. It's also up to them to decide whether they want information to be available for research. But as they have volunteered to be part of research projects, most of them also do that. So we export data for Harald's research in an anonymous form. So that's kind of the first exploitation verification of the principles. The second was, not surprising perhaps, COVID-19 making results available for non-Norwegians in Norway, as they did not have a Norwegian ID number. People needed, or the healthcare in Norway needed some way to provide information for people with international phone numbers. So that's the second verification example, based on the same architectural principles, the same database. And the third we're doing now is on medication, because that's really on top of all patients' list, is to have a correct, complete, updated medication list. So that's our third verification, and that's what we're working on at the moment. There are two reasons for working on this. One is that it's on the top list of all patients. The other is that we're going to participate in a project called Gravitate Health. It's an IMI project, and I think the budget is about 18 million euros. It's not formally signed yet, but we're the only group in final negotiation, so it will, unless something dramatically happens, it will start in November. So we will use capable to make standardized drug information available. And so this is what we have planned. So we're talking with Harald about extending the sleep diary application. For instance, discussing information. So we're now implementing generic methods for discussing any part of any information in your database with any person you want to discuss it with, which can include your doctor or your mother or your children or your neighbor or whoever you want to invite. So that's roughly essential, the important part of capable. So thank you for inviting me.
Thank you very much, Peter. I see such tremendous potential in patient reported data mechanisms. I mean, there are groups out there like Harvard Sleep Epidemiology Research Center has myapnea.org, which is collecting a lot of data. There are other opportunities. And I think, you know, with our work that is going to be coming out to create a patient-based organization, we could get data from populations that are out there suffering. And I see also potential crossover from patient populations reporting data with cohorts in different groups. So thank you very much. I want to welcome Carlos O'Connor-Reyna, or Carlos Reyna O'Connor, rather. Carlos is an ENT and sleep specialist from Spain, who studied myofunctional therapy with us going back a few years ago and was very quickly inspired. And I think he has a great reputation in Spain and around Europe. And I congratulate you on your recent publications and look forward to more publications yet to come. Thank you, Carlos.
Thank you, Mark. It's a real pleasure to be here. I am going to share my screen. Well, really first of all, I have to thanks, because my starting with my functional therapy was with your institute. So all the information that I can offer to my patients is mostly learning with you. And well, I have to speak that my functional therapy we use with the sleep disorder breathing, we use with the sleep apnea. And one of the things is that really changed completely our point of view when we treat this kind of patients. We think that there are further treatments like only surgery, only CPAP, only advanced devices. The main problem that we have when we are talking about myofunctional therapy in sleep disorder breathing is that it's criticized because it's not phenotyping the patients. We need what is the real clue, what is the real key to be treated. So it's one of the things that we are studying. On the other side, we don't have unified exercises. Our publications, they are using different exercises that they don't give a basis, scientific basis to support this treatment. On the other side, there is a lack of measuring outcomes, and they need to measure them in order to provide the patient the proper feedback to provide adherence, because adherence is other problem that we have. So that's the reason we create this app. We create an app based on my functional therapy. After several years of studying, when we were with you, we were having some devices, and the objective is that we can have a program of exercises that the patient can interact with the phone. It's very important that we are creating an app that can the patient interact with the phone. Is going to give information to the trainer. That is, in this case, as has told Harald, there is a lot of legal problems with this kind of apps. So we are talking about trainer, not medical. So in this case, the trainer is giving information about the activity of the sportman. In this case, could be the patient. But on the other side, we can create some plugin, some interactions, some using the technology from the phone to create a therapy. So that's the reason we designed this app. This is called airway. It's called 2 years ago. I have to, of course, to tell that I have a disclosure interest with this app. But the reason is that we create this because in this way, this is the information that has the therapist. We know how are the exercises provided by the patient. We know that he's a good boy. And also we give feedback in the way that the patient can directly interact with us if he has any problem. So it's a good way that with this, we can provide adherence to the patient. This is the way that works the app. In this way, when the people has tried to criticize, they say, oh, this lady is only licking the phone. It's not true. It's creating a proper feedback. There is a sound feedback. There is a visual feedback. And the way that the lady is touching the phone is especially that is improving the proprioceptive disease, because sleep apnea is more than only an obstruction sleep apnea. There are proprioceptive problems, there are sensitive problems, and we are investigating that with this app we can improve. This is a way that the best way to train this kind of patients when they're asking sensory motor in a disease like sleep apnea. When you are giving proprioceptive training like this, is the way that you touch with the tongue, the phone, you are improving this kind of deficits that they are very common and well studied in the OSAT patients. While we have several reports and several publications, I am going to speak about them. I want to thank Tara Hart speaking about the IOP. We think that it's mandatory to use the IOP in a sleep disorder consultation with the ENT. I always go with my IOP anywhere. But we are very proud to introduce, this is the first time that we're going to introduce some results, the results of our randomized clinical trial that is the first done in the world with severe sleep apnea. When we are talking about a randomized clinical trial with a severe sleep apnea treated by an app, it's really complicated. It's not easy. And of course, it has been done with all the warranty that is for my hospital group. I cannot ask the permission. It must be a hospital group. So you can have all the details in this address. This is the American word. But the idea is, the question was that I have a pulmonology department that does not believe me, does not believe myofunctional therapy. And he decides to say, okay, well, let's go. We are going to try if your app works, but we are going to try not with moderate sleep apnea has been reported to know. We are going to try with severe sleep apnea. So let's go. So he tried, there was a randomized prospective clinical trial with patients that within 3 months, there was a control that there will be no therapy at all. And the other treatment, the other group will be receive only exercises with our app. In between our measurements, we include the IOP. The IOP are mandatory. We use the auto saturation and all the polysomnography records. This is the exclusion, where we exclude patients with complete nose obstruction, tongue tie. Well, basically, we can differentiate that when we are talking about the sleep patient, the OSA patient there are two kinds. The patient that fails with the tongue, that this is the golden tie, and the patient that has problems with myofunctional therapy, that is the tongue tie. We have to differentiate these two types of patients because the different therapy could be achieved with the therapy. This is the evolution of the clinical trial. We have at the starting, we have 60 patients. We have the control group. It was very difficult to keep patients without therapy when you didn't notice that they are having severe sleep apnea. From the control group that we have only in the end, they reach 10, but with the therapy group in there, we have 18. So at the baseline measurements, there will be no statistical significance between the two groups. Both groups that will, the control group and the airway gym, in the beginning, there was no any comorbidities that could affect the final result. But after 3 months of oxygen therapy in the control group and the airway gym, we found really significant difference. What are the first significant difference? What we're looking for? We were looking for AHE. I was significant. The patients only doing the exercises that improved from 44 to 20. And what is very important also, we find a change in the IOP. For 59, they changed to 59, also in the tongue and also in the lips, because this found that we have a correlation with the strength that with these muscles with the score of the EAH. Of course, also changed the saturation. There was no change in the other score. The questionnaire we changed in the award. We have not changed in the Pittsburgh. And here we have the scale of the difference, and we can see that we have difficulties with the control group, but with the airway group, you can see how really they improve severely the age. This is the really interesting, where we are now trying to report our manuscript because it's now under review. It's very difficult to explain to the reviewer what happens with the IOP. It's really a mess. So we find here that if you increase the strength of the IOP, you can see here how the IOG grim increased with a significant way. This is correlated with an improvement in the AHA, but this is difficult to explain with the reviewer because they do not know absolutely nothing about IOP. In the control group, if you don't do exercises, there will be no change with IOP. And also this which happens with the IOP in the lips. Well, this is, I know that this now is under review, we are pending of revision, but it's really very satisfying that you have created something that can help so many people in some easy way and also in some universal way. So now we are trying to keep working because we need to polish them. But I think that saves the world that this kind of therapy is worth enough. As I told you, in patients with myotonic problem, more than myofunctional. Myofunctional, we derive directly to the myofunctional therapies, and the patient that has the sleep apnea only with the tongue, we create this app is a very good option.
Well, thank you very much, Carlos. It's really exciting to see this. I can't wait to read your newest paper. I hope it gets published soon. Really, just a comment. Like I mentioned at the beginning of this session, when you think about the patients that are out there suffering, perhaps even in the hundreds of millions who might find some relief. Of course, as you said, as others have really indicated in the Congress, we need to phenotype these patients, but when we have just a really relative handful of clinicians who are trained in myofunctional therapy and such a wide spectrum of clinical competency, such as it is in even training, we have people, saying, take our weekend course and you'll be set, good to go. Or, people studying, for 180 hours. So there's a wide degree, but being able to look at ways of delivering care through gamification, through apps, is really about scaling up and meeting the opportunity with technology. So thank you for that. And it leads me into the next team we're going to introduce here, which are also looking at these kind of questions and scaling up to address this great need. It's a great story they have and how they came to it. But I'll introduce first Umesh Goswami, who is pulmonary critical care and sleep medicine specialist from University of Minnesota School of Medicine. Umesh, thank you for being here today, and you'll be followed quickly by your colleague and partner, Brian Crone, who I'll introduce briefly as well, or perhaps you will. Thank you, Umesh.
Yeah, well, thank you, Mark. I will invite Brian to join me right away. I'm one of the sleep medicine physicians at University of Minnesota, as Mark mentioned. I partnered with Brian, who has a lot of research experience and entrepreneurial experience, and Brian and I together worked on finding solutions to scale up the myofunctional therapy for treatment of sleep-related breathing disorders. The solution that we present is an iPhone app, which adds gamification technology to increase the impact and reach of myofunctional therapy. And I'll invite Brian to put up some slides.
Cool. Awesome. Hi, everyone. Thanks, Umesh. Let's see if I can share my screen here. Well, as that's kind of coming through, I'll introduce myself. As Umesh said, I have a background in both academic research as well as in software development and entrepreneurship. And what I really enjoy is finding good science and good research and then trying to commercialize that and bring that out into the world. And what's been really fun has been do this with myofunctional therapy with a lot of the great research that Umesh and some of the people at University of Minnesota have done. And we developed this app called Soundly. And Soundly is this myofunctional therapy that's been gamified. But I wanted to share a little bit about our overall philosophy on how we, how do you scale something like myofunctional therapy? How do you really have that big global impact that we're looking for? And this panel from all these excellent experts is really the first step is identifying which therapies work for which patients, and then conducting really high quality randomized studies on efficacy to prove that they actually work within the lab. But what also I think is really interesting is gathering that real world data. And it's really cool to see the work that Harold and Carlos and everyone are doing to really interact with this in the real world setting. So getting it out of just the lab. And what we did app and with our little product was we started with identifying these two vocalizations, this knee sound and a gnaw sound, a really simple therapy, and use that to look at snoring. And we built this little gamified app where you say knee, knee, knee to move this character to the left, and gnaw, gnaw, gnaw to move it to the right. And so by saying knee, gnaw, you play this little game and therapy. We found that with about 1,000 to 2,000 of these little vocalizations, we conducted a small pilot study, and we're able to show that that did indeed reduce snoring, just this one simple therapy. Now, of course, the next step is to expand this out, look at more therapies, more ways to encourage users to do it with the gamification and just behavioral change applications and features to bring into that. And the cool thing is because this was for snoring, we were able to get it out into the world and get user feedback right away. So we have, I think, over 400 some ratings now, but users like it. They're willing to do it. They're reporting positive results and testimonials, and we're using that information to then do this cycle again. And now we're targeting, more therapies and research specific on sleep apnea. So we're working right now to do that. And Umesh, you can wrap us up. Maybe just tell us share a little bit what we're doing right now, and then we'll hand it off.
Exactly. Well, so the problems with the current systems has already been identified. First of all, most of the systems, the technology has been developed is mostly focused on diagnostics, both in the clinical realm, but also in the consumer realm. But providing therapy by technology is still limited, especially technology that can be really consumer focused and can be used in people's hands. So, I'm so excited to see what Carlos has done with Airway Gym app and other kind of results that he has produced with obstructive sleep apnea. Our original focus was only on snoring. However, we have a study that was recently funded by the US National Institutes of Health, looking at identifying protocols for myofunctional therapy that can be delivered through digital or gamified therapy in order to treat obstructive sleep apnea. So not only just focus on snoring, but also moving our focus to obstructive sleep apnea. After we have identified that, the next thing would be to work on phenotyping. How do we identify patients who are going to benefit the most from myofunctional therapy as a potential treatment for their sleep apnea? And I will hand this back to you, Brian.
Awesome, cool. Well, I think that's everything from our side of things. So thank you, Mark, for organizing this panel. It's just great to see all the excellent work that's out there, and expect to see a lot more myofunctional therapy scaling in the next year or two. Thanks.
So we're so excited. The more information that gets out there, the more demand there's going to be, because this stuff works, as we all know. So we're really excited about that. Which brings us Heidi van Ravenhorst-Bell. Heidi, are you here? Heidi is she's a dean at University of Wichita, and she has a tremendous interdisciplinary approach. She is developing some great technology as it relates to myofunctional disorders. So Heidi, thank you very much for being here today. She's a recipient of a AMS Rising Star Investigator Award at our third Congress in Rome 2 years ago. Thank you, Heidi, for your work.
Thank you for having me, and hello, everybody. Sorry for the late entry. I actually am also faculty, so I had 2 classes I already taught this morning and then jumped on once my students were done with all of their questions. So I'm sorry I missed all of the presentations up until I jumped in on the end part of Umesh, I believe it was, or maybe, not sure. Oh no, Carlos. Carlos is who I jumped in on. So I got to see a little bit. So with that, so a little bit more background just to kind of help you. I'm actually an exercise physiologist. And then I have a doctorate in communication sciences and disorders. And then I also was raised in a very entrepreneurial household. And so through the years, I've been a part of 3 different companies, in addition to all of the academia and research that I have been a part of. And so with this interdisciplinary, when I was doing my doctorate in CSD, it quickly became apparent to me there were some very obvious voids within not only speech language pathology, but dysphagia. And then I was quickly introduced into sleep medicine and then OMT. And it just totally made sense. Just like within the skeletal system and the physiological and biological, I think that this image here on the left-hand side does a great introductory piece on how many systems are actually, and this is just one quick snapshot of the thousands of systems that are relevant when we think about why there's this challenge or this breakdown. And when you think about this, all of these systems, for the most part, we are only looking at the symptom to try to figure out what's going on because everything is internal. And so we really are limited to understand what is happening, because when you think about the tongue, there's so much more that it impacts than just being able to swallow or just being able to breathe, because what is actually happening during the day? As humans, we have function, we have performance, but we also have habits. And it's those habitual habits that we have to identify. And when we go into a clinic setting, it's our first challenge, because in a clinic setting, we quite often are already instructing the subject or the patient on what we want them to do or try to do. And we can identify whether they were able to successfully complete that task or not. But what are they actually doing the other 23 hours out of the day when they're not with us? Because if we can't, we're very limited to what we can fix in a 1 hour window, once a week, 2 times a week, if you're lucky, 3 times a week. And then what's happening in there? So you have first that restriction quite often of the clinical setting. And then we have these internal cavity organs. What is that tongue actually doing when I'm not telling them to lift their tongue to their upper palate or to stick their tongue out, elevate, depress? Yeah, can they do that in front of me? But what are they doing the other times of the day? A dentist can often look in your mouth and tell if you have a kiddo who has a tongue thrust just by the way that the teeth are being moved. But how do I now correct that kiddo from doing that tongue thrust the rest of the time? Or you have a patient who has sleep apnea. Are they a lazy mouth breather during the day? Because if they're a lazy mouth breather during the day, that means that during the day, they're not training their tongue to remain up on the upper palate in its natural resting posture, which means then when they fall asleep and the tone of their tongue starts to relax, it's going to be more likely that the tongue is going to fall back because they haven't trained it during the day to stay up in its resting posture. So how do I change that habit if I don't know what's happening all day? And then there's the patient individuality, which I heard Brian and Uma speak about, and I'm sure many of you did as well. Because when you meet one patient, just like with autism, when you meet one autistic kid, you meet one autistic child. And that's the same whether it's an individual with sleep apnea or dysphagia or some type of articulatory disorder. There's commonalities, but there's still so much individuality and uniqueness that we have to figure out, how do I help this person specifically? And then there's the lack of evidence-based practice, which Mark and all the OMT team, as well as all of you on here, have tried to make a huge impact. And it's just all of us continuing to work together to continue to establish that evidence-based literature to show that the different systems that we're putting into place actually are working. So what is the solution? And I think all of us are a part of that. It's the innovation and creativity, but I think the biggest piece is the collaboration. Because every single one of us sitting here on this Zoom session, as well as all those that have attended throughout the last month, bring a different lens and scope. As an exercise physiologist, there were so many things that I was able to see that if I had been conditioned coming up in communication sciences and disorders and didn't have that exercise background, I would have never even conceptualized the ideas that I quickly was able to identify those voids. So I think until we actually begin to collaborate that's going to be a real critical piece. I lost my slide, so I'm not sure. There it is. Okay. So one of the things, and I introduced this when 2 years ago in Rome, and then had the chance to share a little bit more at ASHA a couple of years ago. And like I said, I'm in academe, and although I am entrepreneurial, academe moves like a turtle. And so fortunately, Parrot has had an NSF I-Corps grant, and right now we're working on an SBIR grant. And so what Parrot, like I was saying, we have this internal organ. And so my primary focus is on the tongue and what is that tongue's habit? And besides asking somebody what to do, I want to know what you're doing the other 23 hours of the day when you're at home, so that I can actually help you correct those bad habits, to then also, so that assists us with screening and therefore diagnosing. And then on the same trajectory, start to still using the Parrot device, implement rehabilitation. And so what Parrot will be able to do, kind of like an Invisalign sitting on the upper palate, it will be able to monitor lingual movement. So I can see where your tongue is moving at within its oral cavity, as well as pressure mapping. So it's identifying where your tongue is actually putting pressure during different movements and activities. And then of course, as you can see here, it will report to a smart device or a computer system to give that output. And then in return, on the back side, it will also have the rehabilitative, which will be specific to the needs. So if it was, for instance, a sleep apnea where they're a lazy mouth breather, then the system, the phone, that everybody has a smartphone on them or a smart watch. And all of a sudden you're going to get some type of a reminder, reposition your tongue, which is telling them that they're a lazy mouth breather, their tongue has dropped down, they need to bring it back up into its natural resting posture. If it's a kiddo and you're trying to re-educate them on not doing a tongue thrust before the dentist puts on braces, because if you put the braces on but you didn't fix the habit, as soon as you take the braces off, you're going to have the same problem again. And so by re-educating them, kind of like a lot of you have shown, kiddos love video games, and it will be, again, training them through video games on what to do with their tongue and not do with their tongue. So again, there's lots of options. Right now, the main thing is that Parrot, without being invasive, will be able to monitor movement and pressure mapping.
Well, thank you very much, Heidi. We're so excited about seeing your SBIR go forward, which I'm sure it will. And you know, we want to see commercialization of products like yours and application. So we're going to shift gears a little bit here. Denise DeWald is a pediatrician and internal medicine specialist who studied myofunctional therapy a number of years ago with us in Chicago, and she kind of, you know, claims that it had a little bit of an impact on her, and she wound up giving up her practice and moving to Cleveland so she could go to Case Western Reserve and be a sleep fellow. And she's just starting a 2-year project with the NIH and looking at myofunctional therapy. And she's a recipient of this year's AMS Hippocrates Gala Rising Star Investigator Award. Oh, sorry. That's right. She won the Chrysalis Award. We created a special award for her because she's emblematic of transformation as well. So thank you very much for your leadership, and we're really excited to be collaborating with you, Denise, and we look forward to great things to come. And she's going to talk a little bit about dreaming about what's possible in technology in the future.
Okay, thanks, Mark. I'll get my slides up here. So I just want to talk, so I'm not quite a thought leader yet. I'm just a sleep fellow or a research fellow, but I want to talk about what sort of technology that would really move forward the basic science of myofunctional therapy. And so in particular, MRI. I think dynamic MRI has enormous potential for elucidating what's actually happening. And so I just want to remind us what sleep apnea really is. So On the left here is a normal airway, which during drug-induced sleep endoscopy is not floppy. You can see the pharyngeal walls, you can see the epiglottis, here's the soft palate. And in people with sleep apnea, it's floppy. So the soft palate is floppy, the muscular pharyngeal walls are floppy. And it's really important to understand the innervation of these structures. So these are innervated by cranial nerves 9 and 10 that feed into the nucleus ambiguus. And this is what I call the holy grail of myofunctional therapy. This is a functional MRI study of just a dry swallow in the scanner of people, young men who were normal without sleep disordered breathing, and then young men with sleep apnea. And this functional MRI measures blood flow in the brain. And what they found was that this was done by Dr. Parthasarathy's group in the University of Arizona, that the nucleus ambiguus lights up in people who are normal, who have normal swallowing, normal breathing during sleep, and it does not light up in people with sleep apnea. And so that's really important because we have to understand what's causing this disuse of the nucleus ambiguus, this disuse of the swallowing center in the brainstem. And then we need to understand how we can turn it back on. And so I think that using a dynamic MRI, and I'm just going to play this, is that this was done back in 2012 by Zhang et al. And that this is technology that's becoming more and more available because of cardiac MRIs is like ultra fast MRI. And so you can see, you can get this beautiful view of what's going on in the tongue. Because like what Heidi just said, is that what's going on in there? We need to understand what's going on in there. And while this wouldn't be something that you could use for every patient, but this is something that will be a really important research tool to understand what is the aberrant swallow and how can we correct it? Like, what do we need to do to correct it? So that's all. That's what I'm trying to do.
Well, that is so exciting, Denise, and we're really excited about what work you're interested in, and we hope to see great things from you in the future. It's really great to see you on this journey and to be witnessing your work and your ambition. So I'm going to introduce our next panelist, Dr. Karen Sproit, who has been such wonderful experience to get to know her. If you ever have occasion, to collaborate with her, she is such a great team member and so passionate and caring and sincere. So this role that I'm in with the AAMS as executive director is a volunteer job. I call it my night job. My day job, I'm managing director of an institute, the Academy of Orofacial Myofunctional Therapy, and I'm excited, to have a little disclosure that our institute is collaborating with INSERM, the French National Institute of Health, to develop a project to help do validation studies and international multi-site research with myofunctional therapy in collaboration with INSERM and Karen Sproit's research lab there. And so we're going to be pretty in the near future getting 3 PhDs focused on producing, at least 20 or so high impact factor journal publications, as well as a body of knowledge retreat, which we're hoping to get off the ground in January of 2021. But thank you very much for your leadership and your passion and your vision, Dr. Sproit.
Hi, Mark. I'm touched. Okay, speechless now. So thank you again for inviting me. And it's with all my heart that I participate in these sessions throughout this month. I've also learned a lot, as Heidi said. So this sharing of many different perspectives is incredible and is exactly what a young field needs. So I listen with a research ear, with a statistical ear, with a neuropsychological ear, and from a sleep perspective to all the talks all the way through this month and also today. And if I can summarize what I've learned today is that actually technology is in the center. So on one side we have health, the promotion, the prevention, and the treatment. And as Dario said, yes, we are mostly focused on treating. But then again, you have this boom with technology, and COVID learned us that technology can move things forward very fast. And then on the other side of technology, you have the collecting of the data, the sharing of the data, as well as what I've learned from Heidi's talk is, the training, the continued training, and not, the 1 hour intervention. So technology is there, but the question is again, and we heard that from the other talks of Capable, who owns the data? Where does the data go? Who shares the data? Who is collecting the data? And then which kind of data? Because as all of us and each of the apps have shown that it all comes in different formats. And then from a research perspective, or even just from a data format, database perspective, to connect all of that is a tremendous work. And I think Darius will know that, and Denise also, anybody that is doing sleep research, the moment we need to start in EDFs and everything converting to make all the different programs talk to each other, it's a headache. So it's wonderful to have COVID move these things forward, unfortunately, because show Zoom, and we would never have had the opportunity to meet and to interact in this format if, we were not forced to do this through Zoom. So technology is there. And so with myofunctional therapy, from what I hear and what Mark and I and the team will discuss further is the objectivity, because the field is blocked a little bit by the objectivity. And I've heard from the group from Brazil and other groups with their apps that there are parameters there. The question is now, who is going to collect it? Who is going to share it? And how are we going to have that mingled into a continued intervention, a continued training of the ones that need it? Because apart from who is collecting and what you are collecting, it is also disease or disorder linked. And if you look at the chats, we already had the point being raised, like, let's try to do some activities, or let's try to give some exercises, or let's give some recommendations. And then it becomes tricky because to who does it apply? And then from the brain plasticity perspective, we also know, and now I'm talking from a neuropsychological point of view, is that if with myofunctional you train and you improve the myofunctional functioning, but if you give random information or you collect random information, just like neuroplasticity, it is functional, it is adaptive, but it can also be maladaptive. And so it's a coin with two sides where you need, as we discussed, those educational certified people, the good research programs right on the spot to really streamline this technology and go in both ways to have it connected. So thank you again for inviting me and listening to all these different people, and hi to some of those that I know very well personally. So thank you, Mark.
Thank you very much, Karen. And it's a real honor now to introduce a dear friend and colleague, Dr. Sharon Keenan, who founded the Palo Alto School of Sleep Medicine, and she helped launch and build the sleep residency program at Stanford School of Medicine, which is kind of like a mothership for many of us around the world. And she's also a colleague in our institute, the AOMT. Sharon, glad to have you here batting cleanup. And also, my heart goes out to you. I don't know if you lost your house recently. There have been tremendous fires in California. Thank you for, soldiering through in our Congress here. And thank you for your passionate dedication to science.
Thank you, Mark. Thanks. And thank God I am talking to you from my house. So I was evacuated, but back again. My heart goes out to so many people that are still suffering. It is a bright and shining star that we turn to, in these moments of time with the world in the state that it's in and the fires raging at this moment. So it's been a refreshing morning. It's been a delightful morning. It's been encouraging and very, 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 very exciting. I would only say just briefly, again, hats off Mark and Samantha for bringing all of these things, all of these wonderful minds together. We've heard throughout the Congress that it is collaboration that will bring us to the next steps. I heard in many folks' presentations echoes of where we were so many years ago with the sleep field. The fact that we have so many brilliant tools at our disposal and that working on things such as standardization and validation is just, it's an honor to be a part of this process. I think that the work that's being done with this group, bringing our thoughtfulness, our consciousness, our considerations to the patient within a society. And as Darius has said, our goal is not only to help individual patients, but to impact society. And we can only do that through collaboration. My own particular group that I might bring to this very important network of individuals is, of course, the sleep technologists. It was just so wonderful to hear Maxime's presentation earlier. We've known each other for decades, and he and Damien are certainly part of the Stanford team for many years, coming through in many different capacities. Damien helped Dr. Dement with the National Commission on Sleep Disorders Research, and I've known Maxime for many years, and we've had the wonderful opportunity of working primarily and directly with the sleep technologists, who I believe are a group that have demonstrated already a certain place in their heart for developing the ideal, the most important support for patients. And I think that it will be the sleep laboratory that will help us integrate these already standardized devices, such as the IOP and such as some of these other beautiful things that are in development. I think it will be the sleep technologists that will help us disseminate the use of these tools and to integrate them. And ideally, as we use these tools, not only as sleep laboratory, but to educate the patients, to give them some sense of control mastery, to be able to identify things that work for them, tools. The integration of gaming into this is a brilliant, brilliant concept. So I have nothing but high praise and gratitude and tremendous, cheering on for the support of everyone who's showing up for these very important discussions that are happening on the new technology. I agree. Somehow the universe has brought us together in this format and this time. It has pointed to and given us insights into the work that needs to be done. I'm grateful to be here and to hear this exciting stuff that's going on, and wish you all the best. May the wind be at your back. There's lots of important work to be done. So thanks again, Mark, Samantha, everyone who's here.
Thank you, Sharon. And, just a couple of points where our institute has trained some sleep technologists. It's actually Darius Logmani sent some of his sleep techs, to study with us, and they were really inspired. And we have Dr. Victor Abdullah, who is president of the College of Otolaryngology in Hong Kong, and who's had sleep tech study with us. And they have done tremendous clinical work in Hong Kong, and Darius's team's been very inspired. I think there's such, tremendous potential. I know we've kind of toyed with the idea of how to make inroads and possible collaboration You know, the American Society of Sleep Technologists has a great sleep training program, and we have some discussions at high level about finding crossover and collaboration, and I look forward to that. And I know we've gone a little bit over kind of our time here, and we want to thank everyone who participated and our Congress registrants. You know, thank you for your courage and inspiration in being here and a part of this. I hope you'll join us for our 7th AMS Forum, 9 a.m. Pacific time on Thursday, the 17th, 1800 hours Paris time, where we'll look at myofunctional therapy and public health. I've been invited to organize 2 late-breaking symposia for the the World Congress of Public Health, which will be virtual next month. It was to be in Rome, but will be virtual in mid-October. So lots of exciting things to come and lots of exciting news to share. Please join us. You'll find us on YouTube and also on facebook.com/aamsinfo.org, where all of these fora will be cataloged and available for the public. Have a wonderful day.